into secondary care. So I'm going to try and keep the talking limited to around 10 minutes and then open that up for the opportunity for questions and discussion. So if we're reflecting back through COVID and thinking back to the first wave, we saw in primary care a reduction in patient activity. There was, for a period of time, a reduction in referrals and less patients presenting to us in primary care. And in that first wave of COVID, we also saw elective care in hospitals stopping while the focus was put on acute care. What's different that we're seeing at the moment in this second wave is this, and we can see this through the digital platforms such as Ask My GP, is a massive increase in activity in primary care, with patients being consulted remotely, delayed presentations to primary care, an increased number of patients with mental health illness, and we're starting to see less well-controlled long-term conditions. And this has all sort of led to an increase in the number of referrals into secondary care. In primary care, we've also, whilst doing a lot of that, been working on things like our most successful flu campaign so far, and one of the largest vaccine rollouts in our history. So just looking at what the data is at the moment and where things are up to in secondary care, the total number of Wigan patients waiting for their first outpatient clinic appointment is now over 27,000 patients. And the backlog of this being more than 18 weeks is now over 10,000. If we look further down into the figures of patients waiting more than 40 weeks, and even those waiting more than 52 weeks, we're still looking at over 3,000 for 40 weeks and just under 1,000 waiting more than a year for their first appointment. And what we're now telling patients is it's likely to be around 18 weeks for their first outpatient appointment. So patients that we're routinely referring into secondary care, it's roughly around a 4-month wait. This isn't unique to Wigan. This is reflective of secondary care across Greater Manchester and nationally. And secondary care have been working hard at trying to reduce that through remote consulting, through telephone consults, and through video consults as well. And it's worth being aware of the picture when we are referring patients, because a lot of the time we can make them aware that this is the current situation as a result of COVID. A referral may put you into that system of where there are over 27,000 people already waiting. And is there an alternative that we can use? When thinking about alternatives to referrals, there are various forms of advice and guidance. Advice and guidance is something I'm particularly passionate about, as it's changed how we view a referral into secondary care and really shifts us from referring in for a face-to-face appointment to a conversation with a specialist in that area for advice and possibly then for an onward referral. There are different forms of advice that we can get, whether that be through the electronic referral system, so through Choose and Book. It can be through helpline phone numbers provided by the Trust. It can be through digital platforms, but again, that's quite limited in its use at the moment, only in mental health services in Wigan. We started the kind of advice and guidance journey probably around 2018, starting with 1 or 2 specialities. And what we've seen is that that's grown now with a lot of engagement from secondary care and use from primary care to include 10 specialisms now in Wigan. And as you can see from the bar chart at the bottom, there is a good level of activity of advice and guidance, which has been fairly consistent through the pandemic, especially April onwards, into secondary care. So often the advice that I would give to a patient is who is either requesting a referral into secondary care or may need a referral into secondary care is just highlighting the 2 options of being referred in routinely, and there could be a 4 to 4.5 month wait for your first outpatient appointment, which again may end up being virtual, or we can do an advice and guidance request through the electronic referral system and get a reply within a week from the consultant in that speciality. And what we're seeing recently is some of those turnaround times are even quicker. So a lot of the replies we're getting through are within 48 hours. And from a patient perspective, they are usually more than happy with an advice request in the first instance. So just to get an idea of how we do from an advice and guidance point of view across Greater Manchester, Wigan Borough CCG is currently the highest referring or highest advice and guidance referral user across Greater Manchester. And when you look across the figures generally, I mean, there is quite a difference across the CCGs, but we're consistently high and showing an increasing number over a period of time as well. Although we are one of the highest users of advice and guidance across Greater Manchester, as with most things, there's quite a large variation between networks and between practices as well. So if we look at the data, so from the graph on the left first with the orange bar chart, this gives an idea of the green line being the number of advice and guidance requests and the orange bars being the number of referrals into secondary care. And when we look at it month by month, there is an increase from just over 1,000 referrals into secondary care in April to over 5,000 referrals a month in October. And if we look at the green line, it doesn't proportionally follow that increase. So where we were doing roughly 270 advice and guidance in April, we're doing about 420 in October. So a lot less advice and guidance in proportion for the overall number of referrals. If we then look at, from a variation point of view, the table at the top, which shows the networks, you can see quite a large difference in activity from one network to another. And when we reduce that to, or change that to rates per 1,000, there's almost a threefold difference from the highest users of advice and guidance in Wigan North and comparing that to the lowest users of advice and guidance. So there's quite a variation between networks in how advice and guidance is used. If we then look at the blue bar chart on the right hand side, it compares within a network two practices and their activities. So again, the orange line being a low using practice of advice and guidance, and the blue chart showing a high using advice and guidance referrer as well. And again, a huge difference of almost 15-fold between those two practices. So again, we are the highest users across Greater Manchester, but there is still huge variation at practice and network level. And the bottom table just gives an idea of those 10 specialities, or 11 on there. I think endocrine isn't currently available in WWL. They are available out of area. You can see the top 5 specialities that we tend to refer to are cardiology and gastroenterology, which were the first to go live from secondary care, hematology, dermatology and gynecology. But across the board, a fairly good uptake across all of those specialities. What I thought I'd do is just to give a couple of examples of advice and guidance and maybe how it was used in these few cases. So I've just pulled off 6 cases used. They're not my cases, some of them might be, but they're a mixture of cases just to reflect different ways that advice and guidance has been used and what the outcomes were for that. So just to begin with, is just making it clear that advice and guidance is not referral avoidance. If it does become a referral, that's absolutely fine. It's an appropriate referral that needs to go into secondary care. The other way I would almost describe advice and guidance is, as we've got used to digital platforms in primary care and patients sending their communication to us, we then decide on our end how we want to respond to that, either being a telephone, a message back, a video consult, or a face-to-face. Advice and guidance almost has that ability to work from a primary to secondary care, where we put things through as a communication. So not specifically we only want advice, but we put it through as a communication, and secondary care can respond to that in a way that is in the best interests of the patient. So the first case was a 45-year-old female, and these are just summaries of the notes. So there was more detail in the notes, but gives an overview of what was there. Is a few weeks of upper abdominal pains, worse with eating, and early satiety. And the question to secondary care was, can an OGD be organised in the current circumstances of COVID, and what to do? The reply that came through from advice and guidance was early satiety and vomiting are warning signs, so needs an urgent OGD. So in this case, it's not prevented or changed a referral, but what it's helped us to do is to triage that referral appropriately into an urgent referral, where I think the initial request was whether a routine referral needed to take place for an OGD. The second case, a 69-year-old male with a history of moderate aortic stenosis, who was meant to have annual echocardiograms, was last done in November 2018, and it's not really clear why, but was lost to follow-up. So an advice and guidance was sent to cardiology, and with the advice you can attach any letters, documents, pictures, etc. that you want to. So we attached an old letter with a previous echocardiogram, and the advice came back was to request an echo on behalf of cardiology, but with the consultant's name on that wanted that doing. The patient then had the echo done within 2 weeks, and a week later had a follow-up over the phone with cardiology to go through the results, and was put back in the system again. So when we're comparing that to the alternative would have been to add this patient to the back of the queue and to wait 4.5 months to see cardiology for an echocardiogram. Within this way round, the patient had had the echo and been sorted within 3 weeks' time. The third case, a 36-year-old male with an Ask My GP request that had come through with pictures of his rosacea, with a simple request of I want to see a dermatologist, and he's already on oral antibiotics. So again, we're able to use the pictures from Ask My GP as part of the request and put that forward to the dermatologist. And the reply was again very, very helpful, where they've graded the rosacea as moderate and advised topical agents with an additional oral antibiotic for 8 to 10 weeks, and to rotate that within cycles. And what they've also done is given an escalation plan for the next 3 months if things aren't settling down. So within a week of the advice, the patient has a treatment plan and a very clear escalation plan. I'll go through those a little bit quicker just for time. So a 74-year-old female with 2 episodes of incidental microscopic hematuria on over 2-week periods with a normal MSU. Now, for some people, it may have been more obvious that that could be a 2-week referral. In this case, the person who sent it through wasn't sure, so sent it through as an advice. Within 48 hours, they got a reply back that this needs to go on a 2-week referral. So again, it may help for those cases where we're not sure the type of referral that needs to go through. It can give us that secondary care input. If something does then need to become a referral, it doesn't need to be a brand new referral. There is an option on advice and guidance to convert that then into a referral and then choose the appropriate clinic. Again, the fifth one, a 34-year-old female with a diagnosis of a 4-month rash, seen 3 different GPs with 3 different diagnoses and 3 different treatment plans. We sent the series of pictures that the patient had sent through Ask My GP over a period of time, and the dermatologist was able to give us a clearer diagnosis of a type of atypical psoriasis with, again, a clear management plan. So in this case, the advice and guidance helped us to get a diagnosis so that we're treating the patient appropriately, rather than trialing many, many different treatments, and also advised about signposting to tier 2 dermatology for psoriasis if things didn't settle down. And the last one, it was an out-of-area referral to endocrine advice and guidance for a 19-year-old with symptoms of an underactive thyroid, but borderline thyroid results and a family history of an underactive thyroid. So that was one of mine that I'd sent through, and it wasn't clear whether to treat or repeat the bloods or what to do next. And again, the advice came back very, very clear that repeat her bloods, and gave very specific bloods in terms of thyroid tests, the antibody for thyroid, vitamin D and cortisol in 3 months' time. And then we can review what the results are to think about treatment. So again, it made it much, much clearer that within a week of those results, I can tell the patient that this is the plan from the endocrinologist. And for me as a GP, it gives me confidence in what I'm doing next. So those are just a few examples of how Ask My GP can be used. If I then, to kind of keep things a little bit shorter, maybe summarize some of those points, that prior to COVID-19 arriving, we'd already seen some delays in outpatient referrals, And with COVID and the reduction in elective activity, we've seen this escalate quite quickly. The electronic referral system, so choose and book advice and guidance, is a viable option for a number of patient presentations, and it does support not only the patient but also the GP, and may not then require referral into secondary care. And there has been a lot of engagement from secondary care to support GPs as well. And as I said, we've been doing this since 2018. And as time's going, we're starting to pick out themes of recurrent advice from secondary care. And through this platform, through the podcast, we can start to develop educational feedback of those common themes into primary care, which may then support us in our future management of patients. And from a data perspective, we're now starting to get more up-to-date data with Tableau, where we can start to monitor those sorts of things as practices, as networks, to kind of see what our current use is of things like advice and guidance. Rob, I'll let you pick that up from there, if that's okay.
Yeah, that's great. Thank you, Nikesh. It's a really useful service, and I think it's a much more satisfying offer to patients, knowing that they're going to wait such long periods of time. I do find that it's a bit more of a satisfying offer, as I say, as far as anticipating what people's experience is going to be waiting for that first clinic appointment. I'm conscious there's only a few of us. We've had a few emails of people who've not managed to come or not managed to join for some reason, which I'm looking into. But I would appreciate those of you who have managed to join us. I've put a link into the chat there, just to give us a little bit of feedback as to the kind of content of today and future topics and things. If you could take a moment just to fill in that survey for us, just so we can kind of guide things going forward, and then we'll take some questions from Nikesh, if that's possible with you. I've not had any questions so far in the chat window, Nikesh. Okay. As you said on your slide, it's kind of anecdotally, it is reducing referrals 2 out of 3, but there's not kind of a conclusive proof on that as to how it's influencing. Are there any ways for those practices that aren't utilising Ask My GP as much as others? Are there kind of suggestions as to how they can achievably do that you've got?
I think there's a couple of ways. I think it's maybe considering, I think initially the understanding of what advice and guidance is. So it's a move away from, as we said before, about reducing referrals, which if it does that inevitably, then fair enough. But it's moving away from referral reduction to an improved patient journey to get the same information. And I think if we look at it in that way, I think advice and guidance provides multiple opportunities to do that for patients. I think once people appreciate how advice and guidance works and the potential benefits, it's then starting to consider what the barriers are. And I think a couple of the barriers that we've seemed to come up across is a digital barrier, so using Choose and Book to do the advice and guidance. And I know there's quite a lot of variation in practices about who does that, whether it's the clinicians, whether it's the admin staff within practices that do the referrals. So it may be, and we're putting through an IT kind of step-by-step guide that might help for practices as well. Once the referral is done, which is similar to how you do a routine referral into an outpatient clinic, the advice coming back again, it can be picked up by the clinician, or probably easier would be to use the admin staff, once an admin staff has been trained to do that, to then paste the advice into the notes and to maybe task the clinician that the advice is returned. So I think there is an IT barrier that's involved. And I think the other part when speaking to other clinicians is maybe not really understanding the role of advice and guidance, and almost looking at it as a potential duplication of asking for advice, and then if it needs a referral, doing a brand new referral into secondary care, and moving away from that to this idea where the referral, if it does need a referral being done, it's simply just a click of a button to convert it into a referral as opposed to a brand new one. So I think moving forward, if I know I do, and some practices may think in that way, is that maybe to think about all routine referrals, to think about maybe it should go to advice and guidance unless you can think of a reason for it not to, rather than a routine referral and can I think of a reason why it should go for advice and guidance. So maybe just changing that mindset of how we view advice and guidance.
Yeah, and I certainly think maybe a suggested policy or something might help people delegate appropriately within a safe sort of system and to their admin staff. We've had a couple of comments in the chat box. Any idea when practices will be getting their data on utilisation?
So we've got the data on utilisation. So Deirdre, O'Brien and Sue have helped with gathering a lot of the data, and that data at practice and network is available. So it's a matter of how practices or networks want to receive that data. I'm always a bit mindful of data being there and it kind of being open to interpretation and comparisons, but it's more to start that conversation. So I think the data then needs to be followed by the narrative of what the data means in context as well, and then maybe supporting practices or within networks to have that conversation about how advice and guidance has worked for those that have used it, and maybe considering the barriers for those that haven't. But that data is available and it can be shared as well.
I've just noticed I've read one thing at a time. Deirdre has said that she'll be sending it out after as well. So thank you for that, Deirdre. The limited feedback we've had so far has been unanimously positive, Nikesh. So I'll end it there unless you've got anything else to add in.
No, that's perfect. Thank you very much, Rob.
Great. So just general comment on as far as these webinars, it is something we're looking to develop, and if there are further content suggestions or suggestions as to different times, different lengths, anything like that, we are open to be to kind of changing it to what we as primary care clinicians want it to be. And really that's what we want it to be, is primary care focused, relevant locally, and we'd welcome any feedback on that. So anyone who has those suggestions, either put it on the survey feedback or get in touch with me personally. But those of you who have managed to join us, thank you very much, and I'll end it there.
Thank
Cheers
you very much.
Bye now.
Thank you. Bye.